Good evening, everyone. On the behalf of Team Dentist Channel Online, I would like to extend a very warm welcome to all of you. I'm Dr. Aditi Mishra, and I'll be the host for today's session on the topic Wisdom About Wisdom Tooth by Dr. Khushal Gangwani. So, before starting with the session, I have few housekeeping notes to make. If you have any doubts during the session, you can put your questions in the question and answer box, and each and every question will be taken up at the end of the session. If you have logged in from Facebook and YouTube Live, you can ask us questions by commenting and we'll be answering them at the end of the session. So, without further ado, I would like to introduce our today's speaker to everyone. Basically, our today's session is a brief introduction for our upcoming workshop, which is one online masterclass for 3 hours on atraumatic extraction technique by Dr. Kushal Gangwani. It's on 27th of February. So, I'll be introducing our speaker to everyone. Dr. Kushal is an oral maxillofacial surgeon and implantologist with a work experience of over 8 years and has treated close to 3,000 patients till date. He is the founder of Oramax Dental Clinic, Juhu, Mumbai. He has graduated from the prestigious Government Dental College and Hospital GDC Mumbai in 2013 and completed his post graduation from Padma Shri Dr. D.Y. Patil University, Pune. Being a university rank holder, he is consultant oral and maxillofacial surgeon in Mumbai. Over to you, sir.
Thank you, Dr. Aditi, for that wonderful introduction. And let me welcome all of you, all my attendees. I can see Aman, Bhavesh, Dr. Sabah, Dr. Vidushi, Madhu, Mohammed, Kasim, Nabila, Prichila. Welcome all of you, Yogesh. So it will be a very interactive and a fun-filled learning session. So I don't believe in one way teaching, but it should be two ways. Like if you have any doubts at any point of the time, please raise your hand, please comment, and we will answer all your doubts. We will keep a separate question Q&A session at the end of the webinar. So without further delay, I will start this. I'll share my screen and we will start with the presentation. Just give me a moment. Yes. Is everybody able to view my screen here?
Yes, sir, it's visible.
And am I audible loud and clear?
Yes, absolutely.
Yes. So my today's topic of the webinar is wisdom about wisdom teeth. We all have, I am sure we must have faced this problem of the wisdom tooth in our practice, in our personal experience about the pain that one goes through that wisdom tooth, right? So let us see what is inside the wisdom, all the wisdom about the wisdom teeth. 45 minutes is a very short duration to cover the entire topic, but I will just take you to a tour about this thing. Very common thing. So let me introduce you to the topic. So let us see the definition of impacted tooth. Basically, we are dealing with the impacted tooth, right? So this is originating from the word impactus. It means a tooth which is completely or partially unerupted and is positioned against another tooth, bone, or soft tissue. So you can see the three words here: tooth, bone, or soft tissue. So it can be impacted inside a tooth, another tooth, or it can be impacted inside a bone, or it can be just covered with a soft tissue. So that its further eruption is unlikely, described according to its anatomic position. So this is a standard definition given by American Society of Oral Surgeons. So basically, it is any kind of a tooth which is partially or completely unerupted beyond the chronological date of eruption. So as we all know, wisdom tooth usually erupt at the age between 17 to 21 years of age. If the patient is beyond 21 years of age, and if the tooth is not erupted, that will be considered as impacted, or it is partially erupted, so it will still be considered as impacted tooth. Okay, terminology is used. So it is also sometimes called as malpose tooth. So it is a tooth which is unerupted or erupted, which is in an abnormal position in the maxilla or mandible. A tooth not having perforated the oral mucosa, early loss of deciduous tooth may cause arrested development teeth. It can also be synonymous with embedded tooth, or it can be partial eruption. A tooth that is incompletely erupted is a partial eruption. The tooth may be seen clinically, but it is frequently malposed, and always covered with soft tissue to some extent. Now, this is an example of a complete bony impaction. The tooth is completely contained within the bone. So as you can see in this OPG, the tooth is completely inside the ramus of the mandible. So it's a complete bony impaction. It can be a partial bony impaction, like half the tooth is inside the bone and a little bit of crown portion is outside of the bone. So it is partially covered with the bone. The tooth may be complete soft tissue impaction and a partial bony impaction. What is potential impaction? Potential impaction means an unerupted tooth that still retains the potential for eruption, but which will most likely not erupt into normal position and function because of obstruction unless surgical intervention occurs. So in this type of cases, we can see that there is sometimes a soft tissue covering, an operculum, which will prevent the eruption of the tooth. So in that case, we can just remove that operculum, operculectomy it's called, or if it is just a little bit of bony covering on top of surface of the occlusal surface, so that's why preventing the tooth to come out. So we can just remove that obstruction, but that is classified here as potential impaction. Okay. Ectopic or displaced tooth. So you can see in this X-ray, what is it? It can be a big lesion. It can be either cyst, or most commonly, this is a patient of ameloblastoma, unicystic ameloblastoma, where you can see a tooth is ectopic if malposed due to congenital factors or displaced by the presence of pathology. So this is a big pathology involving the entire ramus and body of the mandible, and the tooth is displaced at one end. So it's called as ectopic or displaced teeth. It can be due to congenital factors, or some patients with some syndromic patients especially have a lot of impacted teeth. Can anybody in the chat box mention any syndrome with have multiple impacted teeth? You can write it on the chat box if you know of any syndrome which has a lot of impacted teeth present. I'm reading all your messages in the chat box, so you can always mention anytime. Okay, so next is. Yes, Miran cleidocranial dysplasia. Very good. That's the correct answer. So ankylosed tooth. Ankylosed teeth, when the cementum of the teeth is fused to the bone and there is no periodontal soft tissue in between, a tooth is considered to be ankylosed. So you all know about ankylosis. Gardner syndrome. Madhu has correctly mentioned Gardner syndrome is correct answer. So yeah, I want all these interactive sessions. So please keep on commenting. Whenever I ask questions, please type it in the chat box. I feel encouraged to speak, So, when we all must have faced this difficulty when you're trying to extract a tooth, the tooth is just not ready to budge. In that cases, it can be an ankylose, where there is a cementum and the bone is fused together. Okay, so that can also be Treacher calling syndrome, Bhavesh Bahilam, correct. Cleidocranial dystosis, very good. So let us see the etiology of impaction. Some patients come to me and they ask, "Why, doctor? Why do we get this wisdom tooth? Why does it cause? What causes the impaction?" So let us see a few reasons. So Nordine points out that withdrawal or elimination of a stimulus. It could be because of that. For about at least 200 years, it has been believed that the civilization could be held responsible for the withdrawal or elimination of a stimulus that is necessary for development of human jaws. So basically, you all know about disuse atrophy. Whenever you don't use that particular organ, it causes atrophy. For the same reason, the lost stimulus is the force demanded for the mastication of hard food. Originally, we had this mastication, the jaws for chewing hard fibrous substances, but our diet has been changed over a period of years. The modern soft diet does not require a decided effort in mastication. And so this growth stimulus of the jaws is lost, resulting in gradually evolutionary reduction in the size of the human jaw. So earlier our jaws were very big. You must have seen the skeletons of our four ancestors. They had a big jaws. But now, because of the dietary habits and everything, evolution, due to genetics also, the jaws have become soft. And the tooth remains the same, 32, right? So the wisdom tooth, they become impacted. They don't have space to come out. That is a reason. Okay, so modern man has impacted teeth, and almost this is so common, And the other reason is soft diet, like I already mentioned, and gradual evolutionary reduction in the size of human jaw. And thus modern man has impacted teeth. There could be other causes of impaction. It could be either local or systemic. The local causes, as pointed out by Berger, they are irregularity in the position and presence of an adjacent tooth. Sometimes the adjacent second molar is positioned in such a way that the third molar does not have space to come out. Density of the overlying or surrounding bone tissue. Sometimes the surrounding or the overlying bone tissue is very thick. It's a cortical kind of a bone. We all know the different densities of bone, D1, D2, D3, D4. So if it is a very thick bone, it does not undergo resorption, and the tooth is not able to perforate that bone and come out, erupt. So that causes impaction. Third, it could be a lack of space due to underdeveloped jaws. The jaws are small, they're not fully developed. It could be because of that. And unduly long retention of the primary teeth. If the primary teeth are caries, or they are not, or they don't fall off automatically, so that causes impaction, right? The most common situation you can imagine is the deciduous canine. The deciduous canine or the deciduous molar does not fall off. It is caries that causes impacted canine, which is most commonly seen, right? Impacted canine because of this reason. Unduly long retention of primary teeth. You can see in this picture how there's a deciduous skin of this canine as well as the lateral incisor. Now, you can see because of this overlying soft tissue, local causes. This could be because of the density of the bone that the tooth is not coming out, thick density of the bone. And this is unduly over-retained primary tooth. You can see this is a primary molar, and this is over-retained, so that is why the tooth underneath, this is the
Sorry for the technical glitch. Doctor will be joining us very soon. Meanwhile, if you have any doubts, you can put your questions in the question and answer box so that we will be answering them at the end of the session.
I'm
Okay.
sorry, I lost connection. I'm back. I'm sorry again. So I'll just share my screen. There was a disruption of my Wi-Fi. Just give me a moment. Okay, so we were here, right? Prenatal, postnatal, and rare condition. These are the systemic causes of impaction. So what are the prenatal causes of impaction? It could be because of hereditary, or it could be miscegenation. Postnatal causes could be rickets, anemia, congenital syphilis, TB, endocranial dysfunctions, and malnutrition. And the rare conditions include credocranial dysostosis, oxycephaly, progeria, achondroplasia, and cleft palate. I'll post this in the chat box for those who are answering all these questions, the hereditary, or conditions. So these are all the conditions in which, it could result in impacted tooth. Let us see the order of impaction. According to Archer, impacted teeth occur in the following order of frequency. So the most common to the least common. The most commonly impacted teeth are maxillary third molars. Then there is mandibular third molars. Then there is maxillary canines. Then mandibular premolars. Then mandibular canines, maxillary premolars, maxillary central incisors, and least common is maxillary lateral incisors. So this is the order of impaction. Now, what are the indications? Why do you remove a wisdom tooth? What are the indications of removal of the wisdom? The first and foremost reason, and the most common reason, is the pericoronitis. As the name suggests, peri means around, coronitis means the coronal portion of the tooth, the flap, So it causes the inflammation, and itis means inflammation. So the inflammation of the tissue surrounding the wisdom tooth is called as pericoronitis. Okay. So how do you define it? It is an acute infection of the soft tissue covering the semi-impacted tooth and the associated follicle. This condition may be due to injury of the operculum, the tissue which is covering the wisdom tooth, that flap, is called as operculum. So by the antagonist third molar, or because of entrapment of food under the operculum. So it could be, sometimes there is a covering of soft tissue over the wisdom tooth, and the opposite side, the upper wisdom tooth, is constantly impacting or hitting that operculum. That results in pericoronitis, or it could be because of the entrapment of food. So what happens is, the area under the flap, it is dark, it inhabits a lot of microorganisms, and it causes food lodgement. So all these conditions are very favorable for infection to happen. So that causes pericoronitis. Okay. Now this is a condition. What are the symptoms of pericoronitis? It presents as trismus. It could be halitosis. It could be pain, severe pain in the region of the affected tooth, which radiates to the ear, to the temporomandibular joint, and sometimes posterior submandibular region also. The conditions are trismus, difficulty in opening the mouth, difficulty in swallowing, intraoral, sometimes extraoral swelling, are all noted. These are the characteristics of pericoronitis. And sometimes even pus discharge. If you press that area, there is pus discharge in severe cases. It could also lead to something called as facial space infections. As we all know, there are different facial spaces around our teeth, which are communicating with the tissues of the face. So usually acute pericoronitis is often responsible for spread of infection to various regions. The infection arising from wisdom tooth may be spread through various planes. If it is in the buccinator, it causes buccinator space infection. And if it is below the masseter, it causes submasseteric space. The masseter is a muscle of mastication. So if it is, it goes below the masseter, so we can see that the patient is unable to open the mouth. It is responsible for opening the mouth. If there are submasseteric spaces involved, the patient cannot open the mouth. There's trismus present. Also, it can spread to medial pterygoid, which is also responsible for opening the mouth, right? So these are the different spaces which can communicate to either of these spaces. The infection can travel. Then dental caries. Sometimes the wisdom tooth is carious. So there is a potential space for food impaction. There is a space. Always you must have seen this clinical presentation. The wisdom tooth is tilted, mesoangularly impacted, and the second molar is like this. So this space which is present between the wisdom tooth crown and this thing causes a lot of cavity, and it also causes decay of the second molar. Most commonly, the patient will come to you because of the pain which is associated because of the second molar, the disto-occlusal cavity, caries, which results in usually root canal. So in that case, what do? Now, first, in this case, if there is a severe pain because of second molar, what you do is first you do the root canal of the second molar, then you surgically remove the third molar, and once the healing is complete, then you put the cap of the second molar, the crown. That is the sequence. Please remember this clinical point, very important, because if you put the cap initially, then while removing the wisdom tooth, the cap may dislodge, right? And again, when you put the cap immediately, then it causes, the cementum will get enlarged and trapped in the socket and can cause infection, dry socket. So this is the proper sequence. First, you do the root canal of second molar, this impaction of the wisdom tooth, and then after 15 days or so, then you put the cap. Now, another reason for impaction, removal of impacted tooth, is localized or generalized neuralgias of head. Neuralgia such as pain in the TMJ. Sometimes the patient will complain of pain in this area or in the ear area. This could be because of the wisdom tooth, right? So it's better to remove this wisdom tooth in such a case. Now, also there is a risk of development of cysts and tumors. According to Keith, about 1.6% chances are there the incidence of dentigerous cyst, and incidence of cyst and tumor formation is 2.31%. And ameloblastoma is rare, 0.14% to 2% according to Shear. Okay, but it increases with age. You can see this is an ameloblastoma. So if you can tell the patient, if you leave it untreated, it could cause a big tumor as big as this, in over a period of years gradually. Also, prior to orthodontic treatment, your orthodontist will suggest you, if they want to do distalization of the teeth, then they will suggest removal of the wisdom tooth, because that occupies a lot of space. And if you want to create space, it is better to remove the wisdom tooth. Now, orthognathic surgery, it is also done prior to orthognathic surgery. Orthognathic is basically a jaw surgery in mandibular sagittal split osteotomies. So usually the wisdom tooth are removed prior to the orthognathic surgery, at least 1 year back. You know, but in case of Lefort 1 osteotomy, the upper jaw, we can do it simultaneously with the orthognathic surgery. And after orthognathic surgery, it is rarely done. So it is always suggested do it 1 year before the planned surgery. Why? Because we want the complete healing to take place, because we are doing a sagittal split over the wisdom tooth area only. So we don't want any kind of healing. Otherwise, it will cause a bad split. Okay, I hope everyone is clear. If you are all understanding, please put a thumbs up in the chat box. Let me see if you are able to grasp this technical terminologies. Now, the other reason is decreased bone support of your second molar. As you can see in this OPG, what can you see? The second molar, because of the wisdom tooth, there is a cyst formation around the wisdom tooth and a lot of bone formation, bone loss is there, right? This arrow. So what is happening is the wisdom tooth is a problem, but there is also loss of bone support for the second molar. In this case, we have to remove the wisdom tooth because there is so much of resorption of the distal bone. If you don't remove the wisdom tooth, even the second molar will start becoming mobile, and we'll have to remove the second molar. So in this case, anybody can suggest what should be the treatment plan? Should we just remove the wisdom tooth like that and leave the bone support, or you can do something else also? Anybody can put in the chat box what treatment will you do here exactly? What is ideal to do here? What procedure you can do after the wisdom tooth removal to get good bone support for the second molar? Bone grafting, yes, Dr. Mayuri. Riddhi Dave, bone grafting. Samudrala, third molar extraction and bone graft. Very good, very good. I was looking for this answer. So what we do is we remove the wisdom tooth. The best is you can put some allograft, alloplast, or any kind of synthetic bone graft, or even autogenous bone graft, just covering the distal surface of your second molar. I'll give you a clinical tip here. In such a case, if you remove the wisdom tooth, the patient will complain of severe sensitivity with respect to second molar. So in this case, it's better to graft that area, graft the socket of the wisdom tooth, and cover the distal surface of the second molar with the bone graft. You can also use a PRF membrane here. Okay, that will cover the defect. Or if you don't have anything, at least place some collagen plug or Abgel. So you cover that area, otherwise the patient will keep on complaining of sensitivity with the second molar. Whenever he drinks or eats anything cold or hot food, that will cause a lot of pain to the patient. Okay, moving on. Impacted teeth under prosthetic appliances. If you're giving a complete denture, lower denture, if there's an impacted wisdom tooth, that will constantly cause pain. So if you just relieve that area, it will cause thinning of the denture base. So it's better to remove the wisdom tooth prior to the denture making. Okay. Now, obstruction of eruption of adjacent tooth. Like I said, in this first X-ray, you can see there's a second molar is also impacted. So in this case, what will you do? Anybody can answer this. In the first X-ray, do we remove both the teeth or we remove only the wisdom tooth? What should we do here if the second molar and the third molar are impacted in this fashion? Yes, only third molar. Why will you remove only third molar? Because we can orthodontically extrude the second molar. Your orthodontist can actually pull out the second molar. We can cause extrusion of the second molar.
कितना टाइम लगता है? हरा वाला से देहरादून रेलवे स्टेशन.
Can you mute yourself, please?
मतलब 5 बजे की ट्रेन है ना. हाँ.
Yeah, so the second reason is resorption of caries associated with. So here you can see how there is because of the second molar pushing into the second molar, third molar, that is called caries. Can you mute yourself, please? Okay. So second, after that, let us see also because of the, if the patient is undergoing cancer treatment or any kind of radiation to the jaws, so it is very important to remove the wisdom tooth before he undergoes radiation if it is impacted. Okay. So what will happen? Otherwise, it will cause osteoradionecrosis. You must have all heard this term. If the radiation, it reduces the blood supply and it will cause infection. So to post radiation, it has to be removed before the radiation. Okay, for and healing should be complete at least 15 days prior to radiation. This is very important concept. Tooth in the line of fracture. It's a controversy. Impacted tooth. If there is an angle fracture of the mandible like this in the wisdom tooth, so should you remove the tooth or not? It's a controversial, but here it is the answer. If it is deeply seated, then it is best to leave it in situ. If it is in the line of fracture with pathology, then you remove it. If it is in the line of fracture, but it is free from pathology and it is too deep, then it is left in situ. Okay. Now, what are the contraindications of wisdom tooth removal? Let us see. Possible damage to adjacent structures. If the removal of an impacted wisdom tooth is likely to result in a loss of adjacent teeth or damage to vital structures like neurovascular bundle, inferior alveolar nerve, or the tooth adjacent tooth, then it is best to leave it in situ. Don't remove the tooth. Second reason is compromised physical status. One of the most significant factors to be considered when removing an impacted tooth is a patient's physical condition and life expectancy. It's a very old patient, 80-year-old patient. You don't remove the wisdom tooth. If it's pregnant, in fact, if it is patient is pregnant in the first or third trimester, you don't remove the wisdom tooth. And if he is not fit to undergo surgery, if he has uncontrolled diabetes, then you don't remove the wisdom tooth. Then prosthetic consideration. What are the prosthetic considerations? So sometimes partially erupted tooth has to be retained, since such a tooth could be utilized as an abutment for a fixed partial denture. If you're giving a fixed partial denture, it could be used as an abutment, right? Even if it is tilted, but you prosthetically you can actually correct it. You can correct the angulation. Then availability of adequate space. If the adequate space is available for the eruption of the unerupted tooth, it is better to retain it. And socioeconomical patients reasons. The patient is not due to fear or because of a socioeconomical condition, you don't remove it. What are the absolute contraindications? Please note this down. The absolute contraindications for wisdom tooth surgery: acute necrotizing ulcerative gingivitis, ENUG. We have all studied this in our perio. ENUG is a severe kind of a bleeding where we don't remove the wisdom tooth. Hemangioma also, if it is uncontrolled or if the patient is okay, Astha is asking me a question. What if the patient is having pericoronitis? Okay, we will answer this at the end of the seminar. Okay. Let me just cancel this. Okay. Now, okay, the hemangioma and thyrotoxicosis. These are the three absolute contraindications of wisdom tooth removal. According to Larry Peterson, the great general contraindications for removal of impacted teeth can be grouped into three primary areas: patient's age, extremes of age, poor health, and surgical damage to adjacent tissue. We already discussed this. Local factors: radiotherapy, teeth in close proximity to tumor, acute infections, you don't remove the wisdom tooth. Systemic factors: uncontrolled diabetes, pregnancy, underlying bleeding disorders, acute blood dyscrasias, morbid cardiac conditions, patients on anticoagulants, steroids, etc. So let us study about impacted third molar. We have some time, so let us in detail study about the surgical anatomy. We all know about the external oblique ridge. You can palpate the external oblique ridge just buckle it to your wisdom tooth, and it goes ascending towards the ascending ramus. So it is a thick roll of convex lateral bone extending from the crest of alveolus to the base of the mandible. This is the mylohyoid ridge. Mylohyoid ridge is medially present, lingually. It declines in height as it passes posteriorly, and it is convex with a thick roll of cortical bone. The base of the alveolar process is in the vicinity of the level of the mylohyoid ridge. The mylohyoid ridge continues posteriorly in an upward sweep towards the third molar region. Below the mylohyoid ridge, there is a concavity in which the medial aspect of the mandible, the submandibular fossa is present. So here there is a concavity. Here the submandibular fossa is present. And on top, there is a lingula, where the external oblique, the inferior alveolar nerve canal passes. There is a retromolar triangle. We have all studied in our oral surgery books. Behind the third molar, there is a depression, roughened area on the upper surface of the mandible, which is bounded by the lingual and the buccal crest of the alveolar ridge. This is a retromolar triangle. So this is the area where you inject the posterior alveolar nerve block, right? Lingual nerve. Lingual nerve is a very important landmark. It is a relatively more superior and more directly associated with the soft tissues immediately adjacent to the mandible with dramatic variation in its position. So it could be superficial or it could be deep, right? That's why we don't touch the lingual flap. You must have heard it that don't touch the lingual flap of the wisdom tooth. Leave it alone. Sometimes the lingual nerve is or very superficial, or sometimes it could be very deep. You don't know. It is very unpredictable. So this is a very awkward or very embarrassing complication, the lingual paresthesia. If you damage the lingual nerve, patient cannot feel the tongue and he'll eat your head for the rest of his life. How do you classify the lower third molar impactions? Winter's classification is standard classification. It could be vertical, it could be horizontal impaction, it could be mesioangular, it could be distoangular. This can occur simultaneously in buccal, lingual, or torsy version, right? According to Pell and Gregory classification, there are two methods. First is relation of the tooth to the ramus of the mandible and second molar. So here there is class 1, class 2, and class 3. What is class 1? Just understand, just forget about the written matter. Class 1 means there is sufficient amount of space present between the ramus and the distal surface of the second molar. मतलब दांत को बाहर आने के लिए there is enough amount of space. That means it is class 1. What is class 2? Class 2 means the space between the ramus and the distal side of the second molar is less than the mesodistal diameter of the third molar. Crown of the third molar, जो दांत है, wisdom tooth है, उसका जो diameter है, the space between the ramus and the second molar is less than the mesodistal diameter of the third molar. That means it is class 2. And what is class 3? Class 3, it is completely inside the ramus. Understood? Class 1, class 2, class 3. Now, the second part of subset of the classification is depth. Now, how deep the wisdom tooth can be position A, position B, and position C. What is position A? Position A means the highest portion of the tooth is on a level or above the occlusal line of the teeth. If you draw a occlusal line from the first molar, second molar, third molar, and if the highest level is above or at the level, then it is position A. If it is below the occlusal level but above the cervical level, then it is position B. And if it is below the cervical level of the second molar, then it is position C. So this is A, B, C. Okay, so we'll skip this. Now we will come to pre-operative assessment. Now we know that the tooth is impacted. So how do we go about it? Very important is informed history and clinical assessment. So you have to take a proper patient's history and do a proper assessment, right? How do we do that? Chief complaint, medical history, local factors, all that. And main important thing is radiological assessment. You take an IOP or RVG, you take OPG, and you take CBCT. Mostly this occlusal view, shift cone technique, we don't do anymore. But sabse pehle, if the mouth opening is good, you immediately take an RVG and see that a tooth, what is the position of the tooth, right? If the mouth opening is not sufficient, if you want a bigger, clear picture, you want to see the nerve, inferior alveolar nerve, then you advise an OPG. In the OPG, if you feel that the nerve is very close to the wisdom tooth roots, then you advise a CBCT, which is a cone beam computed tomography, where you exactly come to know whether the nerve is lingual, whether the nerve is buccal, or how far or very close is the nerve. The radiograph must be carefully examined with reference to the following factors. You should see all these factors in the radiograph. Remember this, the amount of root formation, whether they are fused or separate roots, what is the width of the roots, what is the curvature, whether it is a favorably curvature or unfavorable curvature, what is the bone texture, what is the position of external oblique ridge, all this you have to consider. All this I'll show in the pictures. How much amount of root formation? Is it 2/3 complete or is it less than 1/3 complete? Now it is fused or flared. Why do you see the roots, whether they're fused or separated? So that you can section accordingly. If you want to do a vertical section, then if there are flared roots, separated roots, then you do a vertical section. If they're fused roots, you just elevate the tooth, right? Favorable or unfavorable curvature. Favorable curvature means if it is favorable to elevate. If you favorable means it will come out like this. If it is like this is favorable curvature. This is unfavorable curvature. If it is unfavorable curvature, then you have to section the tooth. That's why we have to see this point. What is the size of the follicle space? What is the bone texture? It is young age has a good bone. In old age, the bone is quite cortical, thick. Young age, the bone is flexible, cancellous, more elastic. So we can elevate the tooth. In old age, you cannot just elevate the tooth. You have to section the tooth. Localization of inferior alveolar canal. This is the roots criteria. Very important. Roots criteria. So if you see either of these in your X-ray, in your OPG, that means the nerve is very close to the tooth. It could be darkening of the root, deflection of the root, narrowing of the root, dark and bifid apex, interruption of white line of the canal, diversion of canal, or narrowing of canal. If you see in either of these things, that means you should suspect that the nerve is very close. Then you have to advise the CBCT. Difficulty, assessment difficulty of the removal. So there is an assessment which is called as Peterson's difficulty index. It means how difficult is the wisdom tooth. Can anybody tell me which is the most difficult wisdom tooth configuration? Mesoangular, distoangular, vertical, horizontal? Type it in the chat box. Now these are Warr lines. Warr lines is basically white, amber, and red. So what is white line, amber line? Amber line is a line drawn from the surface of the bone on the distal aspect of the third molar and to the crest of the interdental septum between the first and second molar. Like this line goes, the bone line. Yes, I can see in the chat box how distoangular, horizontal, mesoangular. Yes, distoangular is the right answer. It's the most difficult to be removed. Red line, what is red line? Red line is an imaginary line drawn from perpendicular from the amber line to the imaginary point of application of the elevator, right? And white line is basically the occlusal level of the first and second molar. So what is the difficulty index? You know, you have to calculate these three lines. So if it is a spatial relation is if it's mesoangular, then you give 1 point. This is just take a snapshot of this and you see calculate the tooth. If it fits in this classification, minimal difficulty is 3 to 4, moderate is 5 to 6, and very difficulty is 7 to 10. So distoangular is very difficult, like you all I've answered it correctly. Now, informed consent, you have to do the surgery. Always take a consent. In my practice, I always take a returned informed consent. You have to tell the patients of all the possible outcomes, complications which can happen after the wisdom tooth. There would be swelling, there would be pain, there would be reduced mouth opening. Sometimes there could be paresthesia. If the tooth is very close to the nerve, you should always take a paresthesia consent. Mention that you will experience paresthesia in the tongue, in the lip, everywhere. It has everything should be very clear. This is a surgery, proper surgery. Just like before the surgery, doctor says a consent. Always take a consent. Okay. Now, pericoronitis. We'll study about little bit about pericoronitis. Pericoronitis is basically soft tissue flap covering the tooth. And how do we treat pericoronitis? It is an inflammation of soft tissue causing severity around the wisdom tooth. Now, how does it happen? So, partial impaction causes pocket formation. Pocket formation will lead to due to poor oral hygiene. It will lead to initiation of pericoronitis. That will, it causes edema of the pericoronal flap and it causes stabilization of infection. This could lead to abscess formation and spread to facial spaces. Like I said, it could spread to your submandibular space, subbuccinator space, or submesenteric space. Or even it can cause a Ludwig's angina, multiple space infection. Now, treatment, how do we treat pericoronitis? It is general treatment is bed rest, soft nourishing protein diet, antibiotics, and analgesics, and the local treatment is conservative method, or you can do a pericoronectomy, operculectomy by removing the overlying flap, cut it off, or you can surgically remove the wisdom tooth. Right? Conservative method includes drainage of abscess. You just incision and drainage you can do, or you can just warm saline. You can just irrigate with a syringe inside the follicular space with either Tabot solution. What is Tabot solution? It's a mixture of iodine, zinc iodide, glycerine, and water. So this actually gives comfort to the patient. And you can use iodine, betadine also. Frequent, tell the patient to do warm salt water gargles. How do you remove this? Okay, so you can use a cautery or you can just hold the flap with a tissue holding forceps and just cut it. But the problem with this is there is a 50% chance of recurrence. So this is not the standard method. So you have to do a wisdom tooth surgery. This was there in the textbooks, but it is better to remove it. Now let us see surgically removal of lower third molar. How do we do? Step by step, I'm going to show you. Please pay very attention. Here, it's a very important aspect, the most important part of the seminar. So armamentarium, you all need to set up this kind of instruments. You should have a standard disimpaction box where you have to keep all these instruments ready. First, you should have a surgical micromotor and handpiece. You should have surgical burrs. Number 8 round burr. This is the number 8 round burr you have to use for bone removal. Or else you can also use a 703 or a 701, 701 or 703 burr. So this is a straight fissure burr you can use. These are surgical burrs. Never use an air rotor for wisdom tooth sectioning or with bone removal. It can cause emphysema. Surgical mallet and chisel were used earlier. Now nobody uses. Minnesota retractors are good retractor, which I use in my practice. This is basically a retractor to reflect the flap, the cheek and the tongue also. Venous retractor is used to retract the tongue during surgical procedure. Now, these are the stages of the operation sequence. Incision, reflection, bone removal, tooth section, delivery, cleanup, sew up, check up, follow up, and write up. Okay. So what are the principles of incision? I'll not go into the details, but see the diagram. Your blade, 15 number blade, you will hold it with your scalpel and it has to be perpendicular. You have to be in one stroke. You cannot give multiple strokes in your incision. It has to be 90 degrees. So these are the parts of incision. This is called as Ward's incision. So how do we do this? First, you have to place an incision, from your second molar, the distal surface of the second molar, at the distal cusp. Just go obliquely down towards your gum, gingiva, right? And you go clavicular around the second molar till the midpoint of the distal surface of your second molar. And this is a distal releasing incision where you go distally along the external oblique ridge. Okay, so it has three limbs, limb A, B, and C. Okay, so this is limb A, this is limb B, and this is limb C. Okay, so basically anterior, clavicular, and distal releasing incision. Three parts, three incisions. This is called as Ward's incision. What is modified was if the tooth is very much deeply impacted, like a class 3 relation inside the ramus, horizontal, then you have to start from your first molar, distal surface of the first molar instead of second molar. So you get a wider flap for better visibility, better access. Now, flap designs could be envelope flap, bayonet flap, L-shaped flap, lingual flap. There are many options of flap, but standard which we do is Ward's incision. Okay, I'll not go into details. Once you have given the incision, you have to use a molds number 9, number 15, number 9 periosteal elevator. Periosteal elevator is used to a reflection of your flap. Then you have to do bone removal. Once you see the bone, you have to do osteotomy. How do you do osteotomy? Why you have to do osteotomy? We have to remove to expose the crown by removing the bone overlying it. If it is completely impacted, you have to remove the overlying crown of the bone with the help of number 8 burr, or else to remove the bone obstructing the pathway for removal of the impacted tooth. And to prepare a fulcrum for support of an elevator, you have to make a purchase point. So you have to just make that kind of a ditch, and then you have to put your elevator and then remove the wisdom tooth. How much bone has to be removed? So you have to be removed till we reach below the height of contour, right? How much amount of bone you have to remove when you're drilling this buccal guttering you're doing? You have to enter the cancellous bone. You should see the bleeding point. Only then that much depth of the bone you have to remove. The entire crown surface should be exposed. Cervical area, till the cervical area of the tooth you have to remove, bone remove, till below the height of contour. Clear? Now osteotomy can be buccal or lingual. We don't do lingual osteotomy because of many complications. We just do buccal osteotomy. Okay, chisel versus burr technique. Burr technique is very simple. Usually you can, if the tooth is completely impacted, you can create these holes with your burr, and you can just join those holes to remove that amount of bone. Now, while you're doing osteotomy, very important to copious irrigation with normal saline. Okay, cold, you can use a chilled or cold saline irrigation that will reduce the swelling. It's a clinical tip from my side. Now, what are the advantages of irrigation? It prevents the heat buildup, it clears the bone chips from the burr floats, and it provides lubrication. Okay, otherwise it causes heat necrosis in the bone. Osteonecrosis happens. So what are the solutions? You can use saline, sterile water, Ringer's lactate, or 1% povidone iodine, but it is better to use saline than betadine. Betadine will cause, reddish or brownish color of fluid. Now, how much apply of pressure and all, everything is mentioned. You don't have to go into these details. Now we go to odontomy or sectioning of the tooth. Why it is very important, this statement. The bone belongs to the patient and the tooth belongs to the surgeon. Bone patient ka hai, daant aapka hai. You are the surgeon, right? So you should remove as less amount of bone as possible, because bone is patient property. You cannot take patient's property much from the patient. Okay, jitna minimal bone hai, you have to remove. But if it is really required, then you remove. Don't unnecessarily remove a lot of bone. Now, what are the advantages of tooth division? Instead of removing the bone, it is better to section the tooth, right? The bone removal is less if you do tooth sectioning. There is a lesser chance of damage to the adjacent tooth. Okay, and the risk of fracture of the jaw is reduced. Imagine if you are removing a lot of bone in the wisdom tooth area, the angle becomes weak. There is a risk of fracture. Instead, you just section the tooth and remove the tooth. That is better option. Also, the danger of injury to the inferior alveolar nerve is reduced. If you apply too much of pressure while elevating the tooth can compress the inferior alveolar nerve. So it's better to section it. Now, I'll not go into these details of sectioning. Once you remove the tooth, you elevate the tooth. You have to do wound toilet. What is tooth? You just can't remove the wisdom tooth and leave it like that and stitch it. You have to clean that area very well. Always the impacted tooth comes with a follicle. Remember this. There always must be a follicle around the wisdom tooth. Search for that follicle. Use a curette, surgical curette, and scrape out that bone, and to scrape out all the soft tissue, granulation tissue from the wisdom tooth, the socket, and nicely you have to remove that follicle also. And after you remove the follicle, you have to, whatever sectioning you have done or a bone removal you have to done, you have to smoothen that bone with the help of bone file. Okay, or you can use a round burr and smoothen the bone. If the bone is not smooth, then it will cause pain and it will cause delayed in healing. And you have to copious irrigation you have to do. This is called as wound toilet. Where irrigation with betadine will remove all the debris and infection. And after that, you have to use closure. You have to close the wound with sutures. Usually I use 3-0 Mer silk or 3-0 silk, or you can use our resorbable sutures like Vicryl and all. So this is how you close. You have to give interrupted sutures. You can also place a tube drain. Sometimes the patient will have a lot of swelling post-op edema. To avoid this, you can use a tube drain or a rubber drain. But usually we don't do this. The edema is self-sufficient. It reduces on its own. Now, what is coronectomy? Or it is also called as intentional partial odontectomy or deliberate vital root retention or intentional root retention. What is this? Let us see. So it is basically the removal of only the crown of the wisdom tooth. The root is left in situ purposely. Why it is done? When the nerve is very close. Somebody has asked me this question. What if the third molar is very close to the nerve? Astha locule. So in this case, we do an odontectomy. If it is touching the nerve, then you know that if you remove the wisdom tooth, the nerve will get damaged. So it is better to just remove the crown. Okay. How do we do this? What are the contraindications of doing it? Teeth with active infection, teeth that are mobile, and teeth that are horizontally impacted. We don't do coronectomy in this case. What is the technique? Here, a conventional flap is there, just reflection, everything is done. You cut the tooth like this, 45 degree, only in vertical impaction cases. 45 degree, you have to cut the tooth like this, and the root which is left behind like this. Okay. And what happens is after a period of time, the root will supra-erupt, right? The nerve, it will come above the nerve, and then second stage surgery, you can do it after about 3 months time, where it has supra-erupted, and then you can remove the root as well. Okay. So this is called as coronectomy. Now let us see the different positions. I have limited time, but I'll quickly wind up in 10 minutes. This is class 1 position B, mesioangular impaction. Okay. In case of mesioangular impaction, how do we do? These are all my case presentations. So this is an impacted tooth. This is clinical presentation. You can't see the tooth at all. Here you have to take a incision. I'm taking an annular flap here along with a releasing incision. So you reflect the flap. You can see the bone there. Then I have exposed the tooth completely. You can see the crown portion. And now I'm doing sectioning of the tooth. Right? This is how I'm doing sectioning. You have to section always at the furcation area, till the furcation area. Or don't do it through and through till the bone. Otherwise, you will damage the inferior alveolar nerve also. So you have to do section only more than half of the tooth, and then put an elevator and break the portion. Okay, this is how you have to break that to separate the two tooths together separately. And first you remove the distal distal root, then you remove the mesial portion of the tooth like this. Okay, this is how the tooth appears after sectioning. Right? After this, then we have to see the wounds. You have to see the socket carefully, and then you do wound toileting. See, there's always a follicle attached. So I've removed the follicle. Then you do irrigation of it betadine and close the wound. So this is horizontal impaction. How do we treat an horizontal impaction? Same procedure. The incision remains the same. You have to reflect. Now you have to do buccal bone guttering, expose the tooth completely. Now here in this case, I'm doing sectioning perpendicular to the long axis of the tooth. Separate the crown and the root separately. Section it like this. Okay. Here also don't go through and through. Otherwise you will cut the nerve. 3/4 of the section you complete, and then with the help of elevator, you just break the remaining portion. First you remove the crown, then you remove the root. For removing the root, you have to make a purchase point, a small purchase point in the root. Put your winter caries elevator on the purchase point and then rotate it. It will come out like this. Okay, then you suture it. What about vertical impaction? Vertical impactions are very easy. So here you just have to drill, make a buccal bone guttering. You have to section you can remove the distal portion of the cusp if it is obstructing like this. And then you just elevate the tooth like this. Okay, mesially. So this is a follicle, see. Post-operative care, very important. After you've done the surgery, what you should do. Now, influence of cryotherapy or cold therapy on the reduction of swelling, pain, and trismus after third molar extraction. Always tell the patient to do immediately. You should always keep in your clinic ice packs. Ice pack, you can tell the patient to do icing for at least half an hour in your clinic. So the swelling is always less. I have personally observed this. Whenever I had undergone wisdom tooth, I done a lot of icing. I myself have got very less swelling. So it is local or systemic application of cold. Where it basically reduces the cell metabolism, and it's long time the patient is pain free because of the icing, and also it reduces the swelling formation. Okay, cryotherapy is very important. Now, it also helps in reducing inflammation, controlling hemorrhage. There would be less bleeding. There would be lesser enzymatic activity, and it is always better. What are the therapeutic agents? What agents you can give to the patient to remove the lessen the swelling? Hyaluronidase. Hyaluronidase is basically an enzyme which breaks the inflammation, and it helps in reducing the swelling. You can give proteolytic enzymes like trypsin, chymotrypsin. Any one drug you can suggest to which has chymotrypsin in it, which reduces the swelling. Somebody in the chat box can mention. So here, Chimorol Fort is a standard drug which I usually give the patient for 5 days course BD. It actually reduces the swelling faster. Serratiopeptidase also, Enzoflam medicine has the serratiopeptidase. It's also a proteolytic enzyme which actually helps in anti-inflammatory action. Corticosteroids, I always in my practice, if the patient doesn't want the swelling, you should ask the patient whether the swelling is okay or you don't want the swelling. If the patient is okay with the swelling, you can either don't give the steroid. If he wants to travel or if he has some job to attend, so better to give a small steroid dose injection. I usually give a Dexa or a Dexona injection, which is dexamethasone, and just 2 ml of Dexa, 8 mg. You can just inject it intramucosally, or you can give it an IM injection in the arm. It helps in reducing the swelling. Now, this is aprotein is also newer concept. It has a human trypsin. It reduces the swelling. This is a medicine which is available. Now, prophylactic antibiotics, whether you should give or not. You should always see that if it is infected, you should give the antibiotic. If there is a pain into the patient, always start the antibiotic beforehand. If there is no infection, if he just wants to do the wisdom tooth removal, but the point here is, why would a patient remove the wisdom tooth if there is no pain, no infection? So always consider that it is infected wisdom tooth, and you have to start with prophylactic antibiotic. Usually I give Augmentin, but you can use your choice. So the wisdom tooth is considered to be clean contaminated or contaminated surgery. So in this case, you have to give an antibiotic post-op also. Okay, so thank you very much for this. I will just quickly, briefly summarize about the complications of third molar surgery. Somebody is asking me about dry socket treatment. So basically, complication of surgery, post-op complication include these 4 main complications are there. Localized alveolar osteitis, which is also called as dry socket, infection, trismus, and paresthesia. So if you have any doubts, you can ask me. I have concluded my seminar. To conclude, I would say the surgical removal of impacted tooth is a stressful experience for many patients, also for surgeons. I strongly believe that the most difficult surgery I have come across, being an oral surgeon, I do all the complicated surgeries. I do oncology, I do ameloblastoma, resection, jaw resection, orthognathic, but I feel the wisdom tooth is the most complicated surgery because it is very unpredictable. You don't know how the tooth will come out. It is like delivering a baby, gynecologists have the tough time. You don't know whether the tooth will come, natural delivery hoga ki C-section hoga. Wisdom tooth is also like that. Whether you have to do a section or you have to do, it will come out by elevation. It's very unpredictable. So it is a more stressful condition. As each patient and each surgical procedure are unique, surgeons should carefully assess the risk factors of removal of impacted tooth by proper diagnosis and choose the correct surgical techniques to avoid surgical complications and minimizing adverse side effects, thereby making the surgical experience more favorable for the patient. The patient will come to you. You have to give them a painless experience, give proper medication, the less traumatic wisdom tooth removal, and there will be minimal amount of complications. Then the patient will be saying that, okay, our doctor has treated me very well. He got the wisdom tooth out really nicely. I didn't have much pain, and he explained to me all the post-op instructions very carefully. Okay. Thank you very much for your kind attention. And thank you, Dentist Channel Online, for giving me this opportunity to present this most important, crucial aspect of my field, wisdom about wisdom tooth. If you have any doubts, you can reach out to
Thank
my email
you.
address.
Thank you so much, Dr. Kushal, for this amazing event. And I request all the participants to, if you have any doubts, you can put your questions in the question and answer box so that we can take up questions one by one. And before going to the question and answer session, I'll just introduce our organization to everyone. So basically, we are coming up with this online masterclass for 3 hours on 27th of Feb with Dr. Kushal Gangwani on atraumatic extraction technique. So I request all the participants to kindly register as soon as possible because we have limited seats left.
Yes, I would also suggest that if you want to enter into implant practice, first you should know how to atraumatically extract the tooth. If you don't know how to atraumatically extract the tooth, then you cannot do implants. So it's very important how to extract this tooth atraumatically, causing minimum trauma. So please attend this masterclass. Register today. It is only 799 rupees, and I'll see you there. And I will answer all your questions now in the chat box. I can see many questions. Let me just open the chat box. Okay. If you have any question, you can still ask away. How do you do lingual split extraction for mandibular third molar? Bhavesh is asking. So, Dr. Bhavesh, we no longer do lingual split extraction because it is a very risky procedure. Here we have to open the lingual flap, and you have to actually use a mallet and chisel technique in this. You split the lingual bone, basically the lingual cortical bone. You have to split away, and then you remove the tooth lingually. But here the chances of lingual nerve paresthesia is very high. So we no longer do this technique, but you just remember that lingual split is involving, you have to completely break open the palate lingual cortical plate of the bone. But here we do the lingual nerve, like I said, it can be superficial, it can be very deep, it is very unpredictable. For that, you have to take an MRI. So we don't do that. So better don't do attempt it. Coronect, okay. When nerve seems to pass to the roots in an IOP X-ray, how do we make out whether the nerve is buccally or lingually placed? Tanu Agarwal, very important, very good question. Tanu, so for this, you have to take a CBCT scan. Okay. There is something called as Frank's tube shift technique. But you have to know whether here in this technique, you can see whether the nerve is overlapping the root or it is far from the root. You have to take two angles, one at perpendicular and one at an angle like this. So if while taking at an angle, if you see that the nerve have gone down, the radiolucency, then you see that the nerve is overlapping. The nerve is not overlapping, it is far from the roots. But it is always better to take a CBCT scan if you are confused whether the nerve is buccally or lingually. Because sometimes it is overlapping. In the OPG, you will see that it is going through the roots, but it is not like that. Mostly it is buccally placed, the nerve canal, and otherwise it is overlapping. So always advise a CBCT when in doubt. Dry socket treatment. Samudrala is asking me. Dry socket treatment is, how do you detect a dry socket first? Immediately within 3 days, after 3 days of extraction, 3 to 7 days ki beech mein the patient is coming to you. You can see there's a lot of halitosis. You can see the bare bone, completely necrosed, white kind of grayish kind of a bone. You will see there, yellowish bone, and you will see that there is a lot of food lodgement. Patient cannot open his mouth properly, and tremendous amount of pain because the entire bone is exposed. Right? So how do you do this? First of all, you have to give LA to the patient, give a block there so that it's numb that area well. After that, you have to curate it, induce the bleeding. Why the dry socket has occurred? Because the patient has not followed the instruction. He has dislodged the bone clot by swallowing or by rinsing his mouth, by smoking. So in this case, you have to induce the bleeding. You can either induce it manually with the help of curating the entire thing by removing all the debris. You can do warm salt water irrigation. Just take a little warm saline and just flush it nicely, remove all the debris. And then after you have done that, you can just place a Zeroe pack, zinc oxide eugenol. We all have this Zeroe cement in our clinics. You can just quickly mix this Zeroe and you can just place it inside the socket, right? Directly. And then it will give immediately relief from the pain to the patient. And Zeroe will obviously undergo resorption over a couple of times. Don't make a very big ball also. Small ball is sufficient. And it'll undergo, you can keep it like that. And once you have induced the bleeding, it's better to suture the area. Otherwise, it will again dislodge the clot. So if you're not given a proper suture, the dry socket is very common. So always suture the area, and instructions, you have to just hammer this point. In my clinic, I always give a pamphlet of instructions. I ask my assistant to repeat the instruction. I gave my instruction. Very important. Patient don't follow the instruction, they'll land up in dry socket. How do you do lingual split technique? I've already mentioned. Can coronectomy be done on distoangular third molar when roots are very close to IAN? Yes, very much. It can be done in either vertical or distoangular third molar cases. If it is very close to the inferior alveolar nerve, you can actually do a coronectomy section in the crown portion. And then after 3 months, when the root is supra erupted, you can remove the root also. If we do coronectomy, should we have to do RCT of roots? Usually it is not required. You don't have to do the RCT of the roots. It's very difficult also to do the RCT of the roots, but you can skip that. You just have to remove the crown portion. Usually the root is embedded inside, so it doesn't cause pain. Is coronectomy good in trismus patients? Well, trismus patients, it is very difficult to treat only. To do a coronectomy, you need a good mouth opening. If the patient is reduced mouth opening, how will you do a coronectomy? But it is not the first option. Remember, only if it is very close to the tooth, if it's touching, involving the nerve, then only. Tanu Agarwal is saying my question is missed. Kindly answer. Tanu, can you please type your question again? Why referred is common? Why referred is common in third molar extraction? I can't understand. Samudrala, what do you mean by this? Why referred is common in third molar extraction? Okay, if there is any other questions, I can answer them. Referred pain. Okay. Referred pain, you mean. So referred pain is common after third molar extraction because, like I said, the wisdom tooth is communicating through different spaces involving. It can be pterygomandibular space, buccinator space. So it is the most common referred pain is because of the wisdom tooth. You know, I recently had a patient who had upper wisdom tooth impacted, and she had pain in front of the ear and behind the ear also. So she had undergone all the treatments, all the other dentist, ENT, but when I did the wisdom tooth removal, she got relief from the pain. So this referred pain is very common. Why it is common? Because there is a network of nerves around the wisdom tooth that causes that pain. Treatment for that, treatment for referred pain is wisdom tooth removal, right? You can give an antibiotic painkiller, but wisdom tooth removal will actually solve the problem. And anyways, you can tell the patient that wisdom tooth is an extra tooth. So even if you remove it, there won't be any harm to it. So you can try that. Okay, anybody else have any questions here?
I guess we are done with all the questions. Okay, so how to remove fractured root tip?
Very important clinical tip I'll suggest. If you have fractured the root tip, if it is a very small root tip left inside, don't remove it. Keep it intact. If it is apical 1/3, it usually undergoes resorption. But if you remove it, it will cause more harm than good. You will damage the nerve. But if there is a good amount of root, you can use this luxators, root tips, or if it is a very small tip, you can actually put your files. You know, this root canal files. You can insert it, and it will etch files, and it will actually you can remove the root tip, or else you can use those winter caries elevators and to remove the root tip fractures. But it is difficult. It's not easy. You have to have a good amount of clinical experience for it. Yes.
So I guess we have answered all the questions. Thank you so much, sir, for such an informative session. And we are totally looking forward for your session on 27th of Feb, which is the online masterclass.
Thank you. Thank you so much, Dr. Aditi Mishra, for allowing me to present this very crucial topic. And I hope all the participants please attend our masterclass on atraumatic extraction. It will be a very useful masterclass for all of you in your clinical practice as well. Thank you once again.
Thank you to all the participants. Thank you, sir. And with this, we are ending today's session. Thank you and have a great evening ahead.
Thank you. Good night.